I'm Lia Jamian, and thank you for watching Boomer Health at Home, the show where we explore the most relevant healthcare topics impacting the baby boomer generation today. As more and more baby boomers seek answers to many times difficult healthcare questions, our goal is to provide ideas, tips, and cutting-edge solutions that will help improve your everyday life and health. It is our hope that you find the following information helpful as you sit back and watch Boomer Health at Home.
Hello and welcome to another episode of Boomer Health at Home, the show where we provide you useful information to keep you happy, healthy, and in charge of your own healthcare plan at home. I'm Ryan Donnelly, your host, and joining me to my left over here is the co-host and soon-to-be father, Brett Pulte.
Well, we still got a few months.
We got a few months, but you know, hey, we don't know when they're watching it. It could be.
Of course.
Brett, how you doing today?
I'm doing really well. I'm excited about today's show. You know, today we're talking about autoimmune diseases with one of the leading up-and-coming rheumatologists, Lia Jamian.
Well, welcome, Dr. Jamian. We appreciate you being on the show today.
Thank you. It's a pleasure to be here.
So you hear a lot of talk about autoimmune diseases and all sorts. What are some of the causes of autoimmune diseases?
So autoimmune diseases in general, unfortunately, we don't know the exact cause. Many of them are multifactorial, meaning there's multiple hit hypothesis. So you have some genetic predisposition and then different environmental factors, and that all play a role and trigger an autoimmune response. But we don't know specifically exactly one cause of autoimmunity. It's more multifactorial.
And now, are men and women both equally susceptible to autoimmune diseases?
Good question. So autoimmune diseases in general, it's difficult to put them all into one basket, under one umbrella, because they are so different from one another. For example, we think of autoimmune diseases more common in females, but there are certain autoimmune conditions that are more common in males. But most will take rheumatoid arthritis, which is the most common rheumatologic autoimmune condition. It has a prevalence 3-to-1 female to male ratio, so more common in females.
And that's, another question I kind of thought of. Are autoimmune diseases, can they be hereditary? Can you get one from one of your parents?
So they can be hereditary, yes. And in general, autoimmune conditions, let's say, and it doesn't have to be the same condition. So let's say you have multiple sclerosis in your family. You might not get multiple sclerosis, but you might get another autoimmune condition. You might get ulcerative colitis or Crohn's disease or thyroid disease or rheumatoid arthritis. So generally, if you are prone to develop an autoimmune condition, you're more prone to develop another autoimmune condition.
Okay.
So do certain population types also come into play with this, based off of where your genetics originated from as well, or?
Yes, they do. If different diseases have different genetic susceptibility.
And a lot of times we're seeing now a lot of different drug commercials, and we're hearing more about RA joint damage. What is RA joint damage?
So rheumatoid arthritis, 20 years ago, you were diagnosed with rheumatoid arthritis, and within 10 years you were so disabled you wouldn't be able to use your hands, you might be in a wheelchair. The development of what we call biologic medications, TNF inhibitors, have changed the overall outcomes of rheumatoid arthritis drastically. So the hallmark of joint damage in rheumatoid arthritis is what we call erosions, which is actually areas of the bone that are essentially absent, so holes in the bone that lead to damage. Our goal as rheumatologists is to prevent the inflammation, because it's the long-standing inflammation uncontrolled, that leads to those erosions. Okay. So the goal is, if we can prevent that inflammation, we can prevent the erosions over time.
So what is early onset with something of this nature, and what ages can some of these symptoms be present?
So for rheumatoid arthritis, the first signs and symptoms would be stiffness and swelling in the hands or feet, knees, elbows, wrists. Typically it's symmetrical, so both sides affected at the same time. And typically patients will complain that they feel worse in the morning. So they're sleeping throughout the night, they wake up, that's when they feel the worst, as they do all day long. So they feel extremely stiff, and it takes over an hour usually for them to loosen up and get some relief. But the inflammation is what eventually will come. Now, the stiffness might come before the inflammation, but typically if we can target that early inflammation, we can avoid the damage. There's different modalities we can use that we didn't have years ago that can help detect the early rheumatoid arthritis, such as imaging modalities, which we follow. For example, if you came to my office and you complained of pain and swelling and stiffness in your fingers, and it's only been going on for a year, we might not see anything on imaging. But we would still treat you. And then we would follow, if we knew that you had rheumatoid arthritis, and then we would follow you and do imaging, let's say again in 2 years, simple x-rays of your hands in 2 years, and see if you had any of those erosions. That would tell us we're not doing our job and we need to be more aggressive with the treatment.
Wow.
So are the diseases typically progressive or kind of hit or miss? Or?
So it depends on which disease we're talking about. Rheumatoid arthritis, untreated, most commonly is progressive, but there are a certain amount of patients, about a third of patients, that will go into remission. Patients most commonly affected with rheumatoid arthritis are in their 30s to 60s. As patients are living as people are living longer, we are now starting to see some of these diseases present later on.
So, interesting. So you're talking about inflammation and stuff. So, I'm just thinking, some viewers at home think, I take care of this. Ibuprofen, anti-inflammatory. But if you have arthritis, how effective could something like over-the-counter ibuprofen be on this sort of condition?
So as far as your run-of-the-mill arthritis, osteoarthritis, which we tend to think more of it's non-inflammatory, so it's not an autoimmune condition. Right. Things like NSAIDs, ibuprofen, Aleve. Don't want to use brand names here.
Yeah, that's true. No free promotion.
Yeah. Those things typically are effective. Tylenol is the first line go-to as far as safety, but with aging population and comorbidities into the picture, NSAIDs might not be the safest medication. So prior to just, popping for ibuprofen, if you have some pain in the knee, would recommend consulting with your physician first.
Yeah.
But you asked about the other medications. There are other medications we would use that target not only the inflammation, but the immune system in general, and regulate the immune system. And those are medications we more commonly use in patients with rheumatologic autoimmune conditions, such as rheumatoid arthritis.
Yeah, I think a lot of people think with Dr. Google they can treat everything at home, but that just proves there's so much more going on. Simple pain, it's important to have that relationship with your doctor, and when in doubt, seek assistance from your doctor. So.
That's right.
So now, is there a link between RA and a cardiovascular disorder?
There are, yes. So, and not only rheumatoid arthritis. Rheumatoid arthritis is probably the most well studied because it's the most prevalent of rheumatologic conditions. But in general, we're now learning more about inflammation and its effect on cardiovascular health. So many conditions, another great example is psoriasis or psoriatic arthritis. The more inflammation you have, the more risk you have for cardiovascular poor cardiovascular outcomes. So just another reason that we need to, people are worried sometimes of the side effect of the medications, but I often present it as the inflammation unchecked has more complications down the line than controlling the inflammation to prevent those comorbidities later on.
Great, so what is the specific class of drugs then that are effective in treating these diseases?
So for certain conditions, we talked about NSAIDs, DMARDs, which is another class of medications, and those are disease-modifying anti-rheumatic drugs. Methotrexate, which is commonly thought of as a chemotherapy agent because it's used in cancer, although we use it at way lower doses. That's probably the most common and the oldest of DMARDs around, and that is used to treat rheumatoid arthritis and several other autoimmune conditions.
Okay. So are the drugs really effective in treating rheumatological diseases?
So treating is difficult to use. I would say managing, and the reason is most autoimmune conditions, you have them, they rarely go into remission, but we manage them and try to control them. They are not curable, so you can't give a drug and then you never have rheumatoid arthritis again. But they are the best, and at least I can't say best, they're the first line for rheumatoid arthritis, these medications. And if they're not working, we step up in therapy. So, using imaging and labs, looking at how much inflammation you have in your body and in your joints, we would then, if you're on one medication such as methotrexate and these scores are increasing, that would trigger us to be more aggressive and step up in therapy to some of the stronger medications like the biologics or TNF inhibitors.
Well, and speaking of joints, has medicinal marijuana helped out with any of this stuff as well? You hear a lot of studies and people talking about that.
So it's difficult because it's not, the large research centers don't have the means of studying them, and you need randomized controlled trials in order to have FDA approval on treatment options. But as far as my patients, probably the most common question is CBD oil. Can they use that on their joints? And there was a mouse study, and they actually put the CBD oil on the mouse pads, and there's different ways that they can study the nociceptive, meaning the painful stimuli in these mice. And they did find that it was lessened with the use of CBD oil. I tell my patients it's not going to hurt. It can be expensive, so do your research on where you get it, and states that it's not, recreationally available everywhere.
Sure. Right.
But it's not going to hurt, and it might help. So,
Interesting.
Yeah.
until we have more information,
Of course.
Yeah. Yeah, I know it's just you hear it in the news, and of course, a lot of news about trying to push it and the medicinal aspects of it. So
yes, as far as probably the best example is for osteoarthritis, because that affects the large majority of the elderly population, that wear and tear arthritis. They recently, in the New England Journal of Medicine, which is the most reputable medical journal, they did a large study with the Medicare population. They have Medicare data. They looked at the Medicare database and the patterns of opioid prescribing in states that had medicinal marijuana and then marijuana that you could get recreationally in dispensary. And they looked at the opioid prescription patterns in those states, and they were significantly less than opioid prescriptions in states where marijuana was illegal.
Wow.
And that's kind of important because we have this huge opioid epidemic here in our country, and we all know the side effects and the unfortunate addictive nature of them. But some of these other drugs that you told us, are there any adverse side effects, or what can someone expect to have happen to them while they're taking these medications.
This is my favorite part when you see pharmaceutical commercials too, is the side effects at the end. So
I know, and death is always in there. They do. We have to remember that the majority of them are so rare. So anytime you're developing a drug, you're looking at how many patients do you have to manage and control their disease with a disadvantageous outcome, and how many patients do you have to, improve outcomes for certain medications. So there's always a balance. If the risk outweighs the potential benefit, we would not use those medications. But typically the benefit outweighs the risk. Most of the visits in the outpatient setting for rheumatology are strictly for drug monitoring. So I see my patients, for example, on methotrexate at least every 3 months, and we're getting complete set of labs looking at liver, kidney function. So there are side effects. They are rare, and we do our best to constantly monitor them in hopes that, which typically is the case, if we catch it early enough, we stop the drug, hold the drug, repeat the labs, and typically things are okay.
Great. So what are some other procedures that rheumatologists perform on patients to relieve some of these symptoms that you spoke about?
So there's different procedures. Some of them are to relieve and some of them are to diagnose, believe it or not. So for example, if you come to me with a swollen knee, there are so many different causes of a swollen knee, and we'll leave trauma aside. So I ask you haven't had any injury to the knee. The best way for us to diagnose what is going on is to actually take a needle and remove some of the fluid within the joint. And we look under a microscope and can make a diagnosis from there. Usually, we hope we can make a diagnosis from there. Now, anytime you have inflammation in a joint, it's not supposed to be there. You have the negative pressure, so that's going to cause a lot of pain. So a lot of times going into that joint and removing some of the fluid is not only diagnostic but also therapeutic. So that would probably be the most common, is aspirating a joint. And we can inject steroids in the joint as well if needed to relieve some of the inflammation acutely.
So now going back to rheumatoid arthritis, can surgery be an option for treatment for it?
So no, and a lot of times, believe it or not, surgery can make things worse if you have active inflammation around. So again, if you're doing surgery, you're not getting to the bottom of the problem, which is actually the immune system. So that's why the medications we use are more effective than surgery, targeting the immune system in general rather than the outcome it had on a joint. Now, with that being said, we do work closely with orthopedic surgeons, most commonly that specialize in hand and feet, because sometimes in rheumatoid arthritis, the damage can lead to certain tendons being unstable, and we rely on our orthopedic surgeons, hand surgeons, to stabilize those tendons. So surgery does come into play. Typically, that's with the damage that's already been done, to stabilize the joint as best as we can, but not for any treatment.
Okay. So does a rheumatologist ever get to perform surgery?
We don't. We did not like our surgery rotation, which is why we went into internal medicine. No. We do like procedures, and we do get to do a fair amount of procedures and joint aspirations, but we would not go into the OR and perform surgery.
Gotcha. So of course, on the show, we like to try to see trends and cutting edge, what's new and on the horizon. So what is the outlook for new treatments with methods for people with like rheumatoid arthritis and all that?
So every day we have more and more drugs that are being developed for rheumatoid arthritis. There's different, and other autoimmune conditions as well. There's different classes of medications. There's these biosimilars, which are essentially the biologics, most commonly Humira, Enbrel. You see advertisements all the time, making drugs that are structurally similar, and they might tweak certain aspects of it that target a certain part of the immune system that we didn't have before. But the overall goal of treatment and management in development of these new drugs is targeting the most specific part of the immune system we can, rather than wiping out the whole immune system, which obviously can lead to, if you're wiping out your defense system, you're more susceptible to infection, you're more susceptible to cancers. So we try to be as specific as we can, and that's why there's research being done every day to try to develop these medications.
So there are new medications coming down the pipeline for us.
Yes, there are every day, and over the past 5 years, there's been many of them.
Yeah, and you start to see, especially around times of like the Super Bowl, you start seeing more and more medications being advertised. So is that something to where it's generally a new medication, or kind of like you said, they're taking and studying the Humiras and things of that nature and making kind of a look-alike?
So there's both, actually. Yeah, so they're doing new treatments and new drugs that we've never seen before, different mechanisms targeting different aspects of the immune system. And then there's also drugs that have been present for a long time that the pharmaceuticals are tweaking in order to, try to avoid a certain complication or adverse effect. So both, developing new things and trying to regulate things that we already have.
So how about you personally within your specialty? Do you have any extra interest in any specific conditions, or?
I do. There's a condition called systemic sclerosis, or Scleroderma, and that has been close to my heart. I've done research on it at Vanderbilt, where I trained. I saw a patient in my residency at Cleveland Clinic that sparked my interest in systemic sclerosis, because at that time in my internal medicine training, I had never seen this condition before. It's extremely rare. And because of my experiences there has been some research done at Vanderbilt, and I wanted to be a part of that.
Wow.
So Scleroderma, or systemic sclerosis, it's an autoimmune condition. It involves fibrosis, or tightening, thickening of the skin that eventually can cause that fibrosis and hardening of your internal organs as well. It's a devastating condition, but we are in the process of trying to develop different modalities of management for it. And for more information, there's a slide at the end that the viewers can visit for a little bit more information on the condition.
Yeah, absolutely. So yeah, and that was, you said there's, I remember before we started filming, you said there's a foundation, people raising money to help with research and stuff too. So hopefully we can, on the slide, I think is a link to go in that as well. So
Yep, and you'll be able to find it on our Ameristaff Nursing Services Facebook page. We'll have a link up there as well.
Awesome.
Wonderful.
So you said you have your interest in Scleroderma. So what are your future plans though?
You asking her on a date? Like, what?
Oh, sure. I'll tell my wife.
So I'm actually getting married at the end of the month, and I'm going.
Wow,
thank you. And I will be going to Connecticut and practicing within a medical group there at the Hartford Hospital Bone and Joint Institute, which is a world-renowned, beautiful facility, state of the art. So I'm anxious to do that and be with my soon-to-be husband. We've been long distance for a while. He's in the medical field too, so the training can be tedious and lead you in different places. So finally we'll be reunited. So
that's awesome. It's just like every other great love story.
And eventually I would like to be a part of a larger academic community, and so I'm anxious for that.
Well, that's good. Well, on behalf, and we're both married, not to each other, but so congratulations on behalf. Welcome to the club.
Thank you.
That's awesome.
So is there one single message that you would like all of our viewers to know?
So when in doubt, see your physician, obviously. I think having an organized medical history, especially as our patients are aging, it's very important to have a medication list with you or somewhere easily accessible with all of your medications, having a family history, getting as much information as you can, and anything that is a new sign or symptom, something you might think, oh, this is normal, or trying to rationalize. It's always better to ask, because these are clues for physicians like myself, and we want to know about all the clues we can. The more clues we have, the better we can make a diagnosis.
That's good. And actually, we push that on the show quite a bit with keep medical history. Now we got a doctor on here to tell them how important it is to date the medication. So I came from EMS. I was a paramedic, and you see stuff on there with medications, and you're like, oh, they still, well, I haven't taken that in years.
Four different bottles on the
Well, so we
counter.
don't know the adverse. So it's kind of, we really want to make sure people do that. So listen to your doctor.
And your family, your friends
Yeah.
can always help out. Or your physician. I would actually recommend to all the viewers, anytime you see your doctor, it might be hard to carry around a list and constantly update it. Take a Ziploc bag and throw all of your pills in it and bring it to the doctor.
Yeah, and are you seeing that it's becoming easier now with, coming into the digital age? Not too many places are keeping hard records anymore. A lot of it's,
Right.
kept in the cloud. Are you seeing that? Is that a little easier on you now?
It is. All of the, what we call EMRs, electronic medical record, or EHRs, electronic health records, they don't all talk the same language. So you might see a physician, in Rochester Hills one day, and then another physician in Bloomfield Hills the other day, or another state, and they don't have the same electronic health system. So you can't see what was done in that other city. But over time, I think that's where it's going, and it does make things easier. It's easier to do a click and cross out a medication than patients no longer taking. So.
Oh, that's wonderful.
Well, that's good. Well, that's all the time we have today. Again, Lia, congratulations on the upcoming Wendy. We'll see our invitation in the mail, right? I'm sure.
I'm sure.
Okay, or we'll crash it, and we're good at that. But no. But congratulations. Thank you for coming on today. You gave us a lot of good information. I know everyone at home enjoyed it. And if you at home have any questions about this show or any other content you've seen on any of our episodes, feel free to call us at area code 248-288-2270, or shoot us an email at boomerhealth@americaremedical.com. Thanks for watching. Have a great day.